So it does, because it adds not only to the survivorship population those who have early stage disease who are disease free, but it also adds an entire population of patients who maybe 20, 25 years ago may not have been alive for a number of years, that are now living longer and longer with chronic disease. So we now have survivors of long-term metastatic disease who are on chronic therapy that have to contend even more so with side effects of treatment on a long-term basis, and still have to figure out how to integrate that or change their lives to be able to accommodate their new lifelong therapy. So I think there is sort of two different populations that are dealing with survivorship issues. One is the early stage population, and that's more of what do I do now that my treatment is done? And then there's the long-term survivor population who's living with metastatic disease, who are still just as much survivors as those who have been through therapy, but their issues are, how do I live with the therapy? How do I live with the toxicities of treatment? And how does that get integrated into this new life that I now have to lead? And in both of those groups, they're still thinking about what they can do. I think specifically about my colon cancer population. So I have early stage survivors who are living many years after their diagnosis, and then I have metastatic survivors who are living on average 2, 3, even more years than that. And both of them have some overlapping commonalities that I can discuss with both populations, but then each population then has specific issues that need to be addressed that are very different than the other population. So survivorship care has to be broad enough, and as providers we have to be willing to provide care across those three components of care, but with different focuses depending on what stage of disease or what component of survivorship an individual person is living in.